Hello everyone, welcome back to my channel. If you haven't been on my channel before, my name is Kristen and this is The Female Edit. So this is part 2 of episode 2 where we sat down with my surgeon and talked about a lot of questions I had in my mind before surgery, after surgery, just in general as I tried to get diagnosed with endometriosis over the course of 9 years. And I know that's the struggle in that uphill battle for so many women. So I really hope these questions help you, or maybe they even help you understand the condition a little bit more if you're supporting a loved one, maybe you're in a relationship with someone that has endometriosis, or you have a family member or a friend, because it is such a complex condition. The awareness is growing, but there's a lot of work to do still on raising awareness, so that's why we're here today. Enjoy the episode. If you have any comments, please add them in, or any questions, or you have the condition and just want to say hi, that's also fine. And I hope this is helpful. Yeah, you actually touched on this a little bit, and I kind of read a bit about it, but there's different stages of endometriosis. Is that recognised across like Europe, US, UK, or is that different per?
Right, it's a very good question. It's an ongoing debate.
Okay.
So if you really want to see how many classifications of endometriosis exist, probably more than 100 officially published.
Oh my God,
right?
that's crazy.
I know, yeah. It's the whole thing about endometriosis is like chaos.
Yeah.
Really.
Yeah, it feels like that.
Yeah, and you get 100 classifications for endometriosis, and I think maybe 5, maybe a little bit longer. There was the cry for help. Guys, we need to standardize our classification system.
Yeah.
And now we have 4 out of 100 which are used in different parts of the world. So the most popular would be the American Fertility Association classification, which gives you stage 1, stage 2, stage 3, stage 4. This is very basic. We say stage 4, it could be the space between the bowel and the vagina is obliterated, but there is no infiltration into the bowel, so it's very superficial disease.
Yeah.
That's stage 4. You also can have stage 4 with infiltration of the bowel in like 5-6 places, with involvement of diaphragm, lung, and that's still stage 4. So what's the stage 4 between stage 1? So that's not so accurate.
Okay.
The new tendencies is to basically create a concise classification, which will, if you look at the figures and numbers, you will sort of have a mental image of what's happening in the patient.
Yeah.
And then we have now 3 classifications which are recently created and which are being used quite a lot. So it's ANSIAN, which is a similar classification when we use for cervical cancer. It's also the AAGL classification, which is designed by American Association of Laparoscopic Gynecology. And there is a UK classification called VNAS. And so they are very sort of similar in their concept and their principle, but they give much more detailed mapping of the disease. Okay. It's not very easy. It's very easy to say stage 4, but that doesn't really reflect what's happening.
Yeah.
And with ANSIAN classification, which is probably I think would be my preferred one to use, you have a table with and you put the table in front of you. You know what you saw in the patient, and you can just mark it, and that creates a score, which you can use across specialties to say this is what I had. ANSIAN classification. Yeah. So but still, not everybody uses it.
Yeah.
So, and if someone who's not using it, for example, who is a fan of American system or AGL or the Fertility Association, they may say, what's this? What these figures and numbers mean to me? There's nothing. So, and I think if we want to standardize the understanding of what endometriosis we had, I think the best way still is to have an unedited video of the surgery.
Yeah. And
for example, for my patients, for patients that my multidisciplinary group operates on, we record video, like the dashcam, edited video footage of the operation, because what was done exactly, what it looked in the beginning of surgery, what it looked in the end, and what happened actually during the surgery. And I think this is the best way of information storage, because if patient ends up in a different country, and we have got a lot of international patients coming to us, and she says, yes, I had a lot of endometriosis, so it doesn't mean anything. So if you get the video, exactly visible what it was like 2 years ago, 3 years ago, and what it is now, it becomes very helpful.
That's interesting. In some ways it actually stops us progressing, like our knowledge and consistency around the disease, if everyone's looking at it in kind of different ways, right? If there's different ways to rate it, then it's hard for everyone to move in the same direction, I suppose.
And standardization of surgery and diagnosis and the whole patient pathway is a big issue, you know, and we're trying really hard to approach maybe as close as possible to aviation, right? Because in aviation everything is standardized. The weather conditions can be different, the turbulence can be crazy, the procedure is standard. The plane takes off, you know, the pre-flight checks, everything tick, 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 the team is ready, sit down, fasten your seatbelts, let's go. Whatever we have on the way can be very, very variable. But the process is standard, so, and that's what we're trying to achieve in surgery and in endometriosis diagnosis. So I'm doing the same operation, but the pathology is different. You know, the circumstances are different. The patient needs and expectations are different. The surgical target is different, but this operation is standard. So we have start here, go there, and that's how it's done. You know.
You specialise in robotic surgery, is that accurate? What makes that different from non-robotic surgery, or why would you recommend that to someone that's thinking about having surgery?
Okay, so I might not finish talking about it.
That's okay.
Yes, previously security was called to escort me from the premises. Robotics, so basically, so traditional way of performing endometriosis surgery is laparoscopy. Okay, so I don't think there's any role for open surgery in endometriosis care anymore. And laparoscopy is something we trained on, something I did for years and years and years. And you know, it was for difficult endometriosis surgery, it was quite challenging because so basically the concept is you have a straight sticks instruments which are long, and you put them in a little hole in the tummy, and you operate with the long sticks on a distance, and someone is holding the camera for you. Okay, so that creates a lot of demand from the surgeon, because if it's a complex case, you end up standing, leaning over the patient with 2 sticks for maybe 6, 7, 9 hours on one leg, and you have back pain, neck pain, and it physically is very demanding for the surgeon to do that. Plus, you're depending on your assistant holding the camera, and if you have like a brilliant assistant who is understanding what's going on in the surgery, because he's another consultant level endometriosis specialist, then you don't have a problem. If you have an assistant who is just, you know, was eager to help, but after 3-4 hours the interest is totally lost, and then you have a camera which is going sort of like horizon on the ship, you know, and that becomes quite difficult, because it's very demanding for assistant, for the surgeon, for the theatre team, and once you are tired and irritated, and the whole thing is you know, quite complex, and you still have to maintain and progress the operation, it becomes very frustrating for the surgeon, and you keep up with it, because, and you say, I was really you know, putting up with it for many years. I chose to do this complex surgery. It makes me a very, very important person in my own eyes, because I can do like this crazy complex surgery. But what you feel afterwards can be quite depressing, because you're exhausted. I remember the times when I was finishing the operating day, sitting in the car, not moving, because it's just no energy left. You know, sitting in the car for half an hour before I can make a move home. And that's what laparoscopic surgery for complex disease looked like. And then robotics is basically the same laparoscopy, only the concept is the same. You operate with the small cuts in the abdomen with a long stick, but you don't have to hold them yourself, because the robot is doing it. So you sit at the console, and you have sensors on your fingers. You have a very nice 3D 4K image from the camera, which you control, which doesn't go sort of wobbly, it doesn't lose interest, it doesn't go suddenly where you don't want it. And the precision of instruments is phenomenal.
Yeah.
It's phenomenal because we can do things we've never been able to do before, like cutting into the bowel by a millimeter and slicing endometriosis from the bowel wall, instead of doing like bowel resection for these diseases, which we didn't have a choice but to do that, remove part of the bowel previously. Now we call it deep shaving, and we can shave very, very precisely without damaging the bowel much, and it opened so many opportunities. But the main principle is simplification of complex tasks. A very complex task becomes simpler and physically much less demanding for the surgeon. You don't have to be scrubbed, you don't have to stay on one leg for 9 hours, because you're at the console, you're sitting down in a comfortable chair, you can stretch and take a break and ask your, for example, colorectal surgeon to take over just for a second, or your other gynecologist to take over the console. And the whole thing becomes, surgery still remains demanding and challenging and complex, but it's how easier this is for the surgeon is amazing. And also, not only for the surgeon, although that's I think is quite important, because it takes like years to train the surgeon, and then they retire at their late 40s just because they cannot carry on for health reasons. You know, if we invested so much money into the surgeon, we want to carry on. So I plan to work until I'm 80. Just because I will have my robot, hopefully. Not only for the surgeons, the patients benefit from it, because the concept of endometriosis is to be as radical as possible to abnormal tissue, to endometriosis, and as gentle as possible to something we don't want to damage, like nerves, the eggs, nerves supplying the pelvis with responsible for sexual function, bowel function, bladder function, and that's all very, very gentle surgery. But on the other hand, it's very radical to what's abnormal, to endometriosis, and the balance is achieved much better with robotics, because you can just see small tiny nerves in the pelvis which you've never seen before. And when I started robotic surgery, I used to jump out of the console and go to a normal screen to see the familiarity of what I'm seeing, because I mean these structures I've never seen before. It's like tiny nerves which I've never seen before laparoscopically. Although laparoscopically we still use 4K monitors and everything, but the visualization is amazing.
That's crazy.
So and the patient benefit, because from my own audits of surgical outcomes, it's much less length of stay in the hospital. They go home quicker. They demand less opioid analgesia. The complications are less. The return to theatre are less. The operating time is less, and the whole thing is really, really designed to make surgery better. So that's robotics.
That's amazing. I definitely didn't think about it from the surgeon side. Like, I was just thinking about how more accurate it is for the patient, but that's interesting to look at it from both angles, and it obviously then provides more consistency patient to patient, I imagine, as well. But
it's just I like to go to analogies with aviation. Just imagine the overtired pilot pedaling away through the Atlantic Ocean, with
it's true.
So you don't want to be on that flight, I can tell you.
Great. You touched on eggs, so obviously a lot when you start to investigate endometriosis as just a patient, all you see everywhere is like infertility, causes infertility, problems with fertility. So do we know, we don't know probably, but do we know why there is that relationship between infertility and endometriosis?
Of course. So first of all, the fertility, so the process of conception can be impacted on many, many levels. Okay, so to be able, I mean, again, in a very simple terms, so to be able to have a baby, one has to have the womb, okay, to carry the baby. Then the fallopian tubes, so the egg and the sperm can meet and fertilize in the fallopian tube. And fallopian tube has to be functional. It's not just a tube like in the plumbing sort of industry. It's a tube with function, so it has little movements of fluid which it creates by moving things backwards and forwards depending on the need. So also you have to have the ovaries with eggs and menstrual cycle, okay, because the eggs need to ripen and ovulation needs to happen. And the whole thing is multi-stage, very complex act of God.
Yeah.
Okay, and for this to go wrong, you don't have to disrupt a lot. You know, one step is disrupted, the whole thing goes.
Yeah.
And endometriosis can attack fertility on many levels. For example, it can create scarring around fallopian tube. Okay. So the tube is blocked, the fluid is filled in the fallopian tube, the whole conception is not possible. It can create adenomyosis, which is endometriosis infiltrating the muscle of the womb. Yeah. The muscle becomes increased, it becomes more irritable, implantation of the embryo can impair just because the uterus is irritable and contractile. Yeah. Okay, so that can impact the pregnancy. The ovary can be totally consumed by endometriosis cysts, and ovarian reserve can be consumed by endometrioma, sort of creating scarring and inflammation and consuming the healthy eggs. Yeah. Again, the whole environment in the pelvis becomes very hostile with all the inflammation chemicals going, with scarring formed. The whole thing becomes very hostile for the pregnancy. So many levels, and the big question is, I mean, what do we need to do to improve it? Okay, do we need to treat endometriosis to improve fertility? And that the answer is not that obvious, because if you look at the big research, until recently, there was no difference in fertility rates if you either treat stage 4 endometriosis or go for IVF straight away. Okay. Recently, there was a lot of evidence that you need to treat endometriosis. Although, again, a chaos. So people with most remarkable severe endometriosis get pregnant without any problems, and people with one spot of endometriosis somewhere in the pelvis cannot get pregnant until you remove that little tiny spot. Okay. So is there any logic? No. So the whole thing becomes very complicated.
That's so interesting. Yeah, I actually didn't realise how, this sounds really silly, but how complex having a baby was until I had endometriosis and started to read about like that hormonal balance. And like you said, it just takes one tiny thing to go wrong. What is the rate of return? Do we see that? Is it consistent across women? Is it very different?
The recurrence.
The recurrence, yeah. And then does it come back in the same places? Does it return in different places?
Okay. Yeah. Again, chaos.
Okay. There's a theme, isn't there?
Yes. Okay. Yeah. So yes, endometriosis can come back. Unfortunately. Again. There is a more complex concept to it. So the chance of it coming back is really depending on many factors. And a lot of factors we don't have any predicting power of. For example, we know that in some patients endometriosis is slow cooking. So you can have one spot of endometriosis since your teenage years until you go menopause. It doesn't grow, doesn't do anything at all, and it's there. We also have endometriosis which we removed 2, 3, 5 years ago, and then in 2 years' time it's like we've never touched it before. It's florid, infiltrating endometriosis, came back from new places, from old places, and there must be some different types of endometriosis with different potential for growing, for infiltrating, for turning into a cancer, which we don't know. Yeah. There's no test to say, yes, we have endometriosis in your tissue biopsy, but we don't know, is that endometriosis aggressive type, or is it a slow cooking type, or is it going to turn into a cancer? There is no test to date to actually predict what's going to happen. Yeah. So, and then that's too complicated for us to even start thinking about. So what we think about on a surgeon's level. So I know that endometriosis, which was removed by excision, eradication, derooting, is less likely to come back. Yeah. Okay. If the surgery was incomplete, that's not coming back. It's already there and is going to progress and going to develop. So that means radicality of surgery is very important thing in recurrence. For example, we know that if we remove endometriosis from the bowel in the radical way, or do bowel resection, the risk of endometriosis coming back on that bowel is literally very, very small, like close to zero. We don't use zero in medicine, but 0% is never happens, but it's very close to 0%.
Okay.
If we do the partial removal of endometriosis from the bowel, it's going to be back. Okay. If we remove endometriosis from the ovary, and endometriosis on the ovary normally is multi-cystic, okay, multiple cysts. And if we have a young patient who is looking to get pregnant, radical removal of endometriosis from the ovary means, apart from endometriosis, we also remove the healthy eggs. Okay, and that's very difficult to say, no, we removed only abnormal tissue, because inevitably you excise the cyst capsule, inevitably you have a layer of healthy eggs to go with it. That's why we measure the ovarian reserve before surgery on the ovaries and see if we can actually offer some egg freezing, for example, before surgery. But then, if we're gentle to the ovaries, they inevitably will leave some disease. Microscopical, we don't leave big lumps of endometriosis, but microscopical disease, which we don't see, or we decide not to slice the ovary into 1,000 pieces just to find a little half a centimeter endometriotic nodule. And that nodule will progress and will recur. So if you ask what's the percentage of endometriosis recurrence of the ovary, is about 20%, 25%. It's because ovary is an egg-containing organ, and we normally be very gentle to it. Okay, so if we say what's the risk of recurrence if we do the deep shaving on the bowel, so laparoscopic data says 10% risk of recurrence in the 5 years interval. With robotic deep shaving, we don't have this data yet, because I mean, for our center we started doing robotics 2021. So, and we've done so far just approaching 500 cases. But we don't have a long-term data. We don't even have a 5 years data for robotic shaving, because, and I think that the data is going to look much better, because you eradicate the disease. You see the healthy tissue once you're done shaving, and that's what makes a complete excision. And things like adenomyosis. Yes, if someone's training pregnancy, you can't remove diffuse adenomyosis without removing the uterus. So you leave the uterus behind just because the fertility is the target, apart from the pain and bowel function, bladder function. So that's leaving endometriosis behind. That means recurrence rate is going to be higher. So again, you see, it's so multifactorial. It's so, with cancer it's more or less clear. So you remove the cancer as radical as possible. You can compromise on ovarian reserve, on sexual function, on bladder function, bowel function, because you preserve the life of the patient. Yes? And most patients will be grateful to live longer, and they can be very happy to sacrifice a lot of things just for survival. Okay? With endometriosis it's slightly different. So nobody's going to die. Okay? But everybody wants a sex life, everybody wants to have a healthy pregnancy, and that becomes quite a big issue. You cannot just simply do the operation and treat everything.
The amount of women that I talk to that their pain reoccurred, or they feel like it's came back, is quite high, but that makes sense if it's only recent that we've started having more robotic surgeries, and we don't really have the data there to show if that's, that reoccurrence is lower. But so many women talk about their symptoms coming back within like 1 to 2 years or something like that.
And that's and you know, we also see these patients. I'm not saying with the perfect surgeons who never have recurrence. We do have recurrence. But a lot of it is incomplete surgery in the first place. But with microscopical disease, which is not visible during the initial surgery, that these areas of invisible endometriosis will progress. And I think for most of our patients who are not planning fertility, like pregnancy straight away after surgery, we suggest we put you on hormonal suppression and until you are ready to get pregnant. Because that is more or less another extra factor in ensuring that endometriosis doesn't come back too quickly.
I think you kind of just touched on it, but hormonal treatment is not the solution, but that is what is out there for women to kind of take as a next step, because I think that was probably part of the journey that I just wasn't anticipating, because you go for years trying to find an answer, and then someone finally tells you have it, you're like, oh, what next? Like, what do I do now? And that's kind of the journey that I've been on, trying to understand like how I can approach life differently to make sure that, yeah, I'm living a healthy life, but then like what are the next options, like egg freezing, hormonal treatment. So yeah, I suppose for anyone that has just been diagnosed, like, what's your biggest piece of advice?
Well, you see, it's very individual, because it really is depending on what the key symptom is. If it's pain, or if it's inability to have intercourse, or it's difficult getting pregnant, the management algorithm should be tailored individually to the patient. It's no, everybody was on the pill, or everybody has hysterectomy. So it doesn't really work like this, because you tailor, you have options, you have a patient, you have symptoms, you have the map, you have a dialogue with the patient. So what shall we do? What is your priority? And if priority is, yes, I want to get rid of endometriosis by excision, and then I want to wait for 2-3 years and then get pregnant. So that makes me think, yes, we have a plan for you. Because yes, we do the radical excision of endometriosis, preserving your fertility, preserving sexual function, bowel function, bladder function, and then we give you, suppressant therapy for these 2 years. We give it initially for 3 months. If it's tolerated well, then it's safe to carry on for longer, and we can do interim sort of checkups like every 6 to 12 months, and then we stop the hormonal suppression, assuming there is no endometriosis coming back. Then we can plan a pregnancy. Try naturally, go for IVF, depends again on the circumstances of the patient. And if someone says, no, I finished my fertility, I have like 17 children, and I don't really plan anymore, and I'm approaching menopause, this endometriosis has been troubling me all my life, let's have radical treatment, remove the womb, the ovaries sometimes, it really depends on what the symptoms are, and bowel resection versus bowel shaving versus discoid bowel resection, so the whole options are available, and it's not a single answer for everyone, so you just need to tailor the treatment to individual patient.
Okay, great. What would you say is advice for someone, because I feel like I have so many friends since I've started talking to people about the condition that feel like they're at that point in the journey where they're lost and they're not being heard, and they have like pain but they're not sure what it is, and they've been sent away from so many GPs or consultants. Like, what do you think is a good first step if they really feel like it is endometriosis, or that they want to kind of pursue that path and find out if it is?
Yeah, so basically you just need to find a specialist, and now there are specialized clinics, and they're very available and searchable by whatever search engine you use. And patient groups as well. So patient groups like the Nancy Luke group, they have a huge database of worldwide list of endometriosis surgeons with who it was created not by because I'm doing endometriosis, everybody come to me. It's based on patient feedbacks. Okay, and I think this is fantastic. You know, it's something that patients create to help situation like you've been fobbed off many times just because nobody wants to listen to you. And then you just need to find a person who will listen, who will know what to do, who would know that you are part of this 7.5 years treatment and diagnosis delay, which is the case in the UK. Okay, and finding a right specialist is a key thing. Okay, and once you're taken on board by the specialist clinic, it's just about anything. I mean, for example, if you not only just endometriosis, you need to find an expert in just about anything.
It's definitely how I ended up finding you. So I asked to be referred to a specialist, and then I actively searched to find someone that I felt was the right fit. So there's definitely a guardian angel looking after me the day that I found you. But I looked at reviews, so I think that would be my piece of advice for anyone, like search until you have the answers, because you kind of in some ways have to take control of your own health at that point, rather than just trusting that someone's going to put you in the right hands. Especially
exactly, going to the doctor doesn't really mean much nowadays.
It's so true.
And you can see the most expensive private doctor and still waste your time. And you can go in the little NHS unit which will have the perfect patient pathway created for this particular problem. You know, it's
So 2 more questions. One is, how do you think the diagnosis and treatment for endometriosis is going to change? Like if you had a magic ball and you were able to see in the future, or how would you like to see it progress? Like what do you think needs to be
well, first of all, I mean, there are some non-invasive tests available, like saliva test and different sort of other, and they're fantastic, you know, but still, I know they exist. I know that they're not cheap, but I would not use them at the moment, because our diagnosis is based on talking to the patient and then imaging and then a laparoscopy. So you can have test positive for endometriosis. What does it tell you? Yes, you probably have endometriosis. But I can tell you if you have endometriosis more or less by spending half an hour talking to the patient.
Or 5 minutes in my case, 2 minutes in my case.
And yeah, I need, once we have this suspicion that is endometriosis, then we do imaging, laparoscopy, and then mapping, and the whole thing becomes, so just yes or no for endometriosis is a good start, maybe. Maybe attract attention of the specialist, but still it's very limited. In terms of what I would like to know about endometriosis is predicting what's going to happen once we remove it. You know, what tissue type, are there any tissue types? Because we suspect that there's a fast growing, slow growing, but we don't have to any tools to quantify this, to take 2 bits of endometriosis from different patients. This is going to stay as we left it, excised, free of disease. This is going to recur. This is going to turn into cancer. We don't have any criteria to do that. And but because endometriosis is very common, it's 10% of women. Okay, it's just like diabetes. You know, everybody talks about diabetes, and you know, endometriosis is the same prevalence. And I think the key thing is awareness of this disease is not made up by the patient. It's a real thing, you know. And directing the patient to a right pathway would be really, really useful, because it can be treated. It can be treated to the point it doesn't come back ever, because you know, we have to accept there's a small risk of it coming back, but we can treat it in a radical way. We can change the pain, improve the quality of life, things like this. It can be done.
Significantly, definitely. It's considered in many ways a whole body disease. Is that accurate? What would you say, are there any secondary conditions we're seeing linked to endometriosis? Because there is that inflammation in the body, and we know then that potentially plays.
Well, it's a hard question to ask, to answer rather. Yes, the whole body is affected. The whole body is, I mean, if you have extensive endometriosis, it affects your just about everything, starting from bladder function, bowel function, sexual function, fertility, you know, general fatigue, general mental health issues, because you're in pain most of the time, you take opioids most of the time, you go to the doctor and nobody listens, and then you say you have to normalize it. You know, is that not all body disease? It is, because the whole body, the whole human being is affected in a very negative way. So whether there is a systemic treatment, like some form of all-body therapy for endometriosis, I'm not aware of one. There are some research going towards the creating of the drugs which will be sort of, you know, make endometriosis go away. But at the moment, we only have surgery and some suppression with hope that it doesn't come back.
Anything else that you'd like to add from your side, or if someone wanted to find you as a surgeon and talk about potentially?
Well, a bit of marketing.
Of course, always.
So basically, like I said, there are, across the UK and in Europe, there are fantastic endometriosis specialists. And from surgeon's point of view, endometriosis world is very, very small. I know most endometriosis surgeons in Europe and States. Because the collaboration was, especially with robotics, the collaboration reached a new level. You know, we know all each other, we know what everybody is doing. We do the video sort of broadcast of our surgeries, we do the teaching, we do the conferences, the international symposiums, and it's the same people meet together and we know all each other. So and there are places where you can have your endometriosis treated to like a really, really good standard. And in terms of our unit, so we have a multidisciplinary team. So we have colorectal surgeons. I work with 3 colorectal surgeons, 3 urologists. We have hepatobiliary surgeon. We have a thoracic surgeon, all robotically trained. So we're all robotic endometriosis center. So we think robotics is a better way of doing surgery. It's certainly bringing better surgeons out of us altogether. And surgery from robotic point of view is much safer, much more efficient. And yes, we can be found London Endometriosis and Advanced Pelvic Surgery Center, and that's us. Yes. Okay, great.
I'll add the link in the bio as well, so anyone that wants to find you has all of the details. But yeah, thank you so much for taking the time to do this. And again, finally diagnosing me after all that time. I literally talk about it to anyone that will listen. So yeah, hopefully this helps that little bit further with awareness, and for anyone that feels like they're alone in that journey or wants more answers. So thank you again. I really appreciate it.
No, really, you were brilliant.
Okay, so that was episode 2. Thank you so much for watching, and I hope it was helpful. To be honest, when I set up this channel, the aim was just really to raise awareness. Like when I was trying to get diagnosed, and even pre-surgery, post-surgery, years following surgery, I didn't feel like there was enough places for me to feel like heard, understood, supported. And there are amazing charities and amazing organisations out there, like the Endometriosis Foundation, as an example, that are doing an incredible job. But I just wanted another place to be able to interact with people that have the condition, and actually it sent me on like a further journey interested in women's health in general, and realizing that there's so many conditions that women struggle with, or just looking at women's health and longevity in general. Like when I started to research more about management of endometriosis, I became so interested in diet and supporting our bodies correctly throughout the month, and thinking about hormonal balance, and if hormonal balance is off, what that looks like day to day in the body, month to month. It's kind of sent me down a path that I'm really interested in. So I want to take you on that journey and share as much as I possibly can without it being incredibly boring. But yeah, if this is of interest to you, definitely hit subscribe, hit like, comment if there's anything else that is on your mind in regards to women's health or endometriosis. I'd love to hear about it. But yeah, thank you so much for watching, and see you soon. Bye.